I'd like to welcome everybody to the session. I know people are still filing in. My name is Lynn Henry. I am a breast medical oncologist at Rogel Cancer Center at the University of Michigan in Ann Arbor. And I'd like to welcome you to the session entitled Genomics for Clinical Research and Cancer Care. As a reminder, we will have three educational talks followed by a question and answer period. So people can either be putting in their questions into the portal as they go along, or they can wait and come up to the microphones at the end. So first, I would like to introduce Dr. Milan Radovich from Caris Life Sciences in Irving, Texas, and he will be presenting on emerging approaches to targeting pathways using precision medicine in breast cancer. Welcome.
Thank you very much, Dr. Henry, and good afternoon, everybody. It's a pleasure to be able to present today to you on emerging approaches to targeting pathways in breast cancer. I also want to thank my distinguished colleagues for sharing a panel today for what should be hopefully a very interesting educational session. So, my disclosures. So for today's outline, what I'd like to do is start off by touching on some exciting new modalities and targetable pathways in breast cancer. Much of what I'll be talking about today, we saw some new data presented at this meeting. I'll then transition into liquid biopsies, and particularly with a focus on clonal hematopoiesis and how that implicates the use of targeted therapies for precision medicine. I'll then dovetail into treatment resistance and the use of liquid biopsies for identifying resistance alterations. And then I'll end off on what I find somewhat probably the most exciting coming on board is digital pathology and AI. So I'm a history buff, and I love to think about precision medicine from a historical perspective, and I think many of us in this room have seen this story unfold over the last 20 years. But obviously, the whole concept of precision medicine really started with the development of targeted therapeutics, with imatinib leading the way. And what we've seen over the last 25 years is just the emergence of numerous agents targeting multiple pathways. Then as we got into the late 2000s, and particularly in 2010s, we saw the proliferation of clinical NGS testing. And I won't go too much into it, as my colleagues will focus on this more. But obviously, the democratization of genomic sequencing to be able to be used for routine clinical care has really revolutionized how we can apply precision medicine for patients. And then in 2020, I think we can all agree the archetypal term for how precision medicine is being done today in research settings and moving forward is artificial intelligence. And I'll touch on that at the end of my talk as well. So when we think about precision medicine and biomarkers, they come largely in three different flavors. The first is a direct biomarker, i.e. We have a drug that goes after a specific molecular target that goes after that actual particular mutation. So examples are like KRAS G12C and sotorasib, or BRAF V600E and dabrafenib, where the drug is going after the particular alteration directly. The second flavor is an indirect biomarker. This is more where we observe a phenotype that is likely to respond to the associated drug. So an example would be high TMB in immunotherapy, MSI, GLOH, and PARP inhibition. And then the third flavor is a pathway biomarker, where we have an altered pathway, but the drug doesn't go after necessarily the specific alteration always, but may go after a particular component of the pathway to elicit an anti-tumor effect. And so examples like this are mutations in homologous recombinations, such as in DNA repair, so i.e. mutations in BRCA1 and the use of PARP inhibitors and other such markers. So in breast cancer, as we know, and as we've heard a lot about at this meeting, there's a phenomenal plethora of established and emerging targetable pathways in breast cancer. Now, be thankful, I will not bore you or insult your intelligence by re-reviewing how to target HER2 or ER and PR. What we do know, though, is that the novel pathways are numerous and varied. We have new targets against a variety of different pathways that are dysregulated in breast cancer. I'm going to highlight a few of these here. And obviously, the ability to target these pathways has really been made possible by the proliferation of NGS, as I stated. Again, my colleagues will go into more detail, but I just want to highlight a recent opinion paper by ASCO that really highlights the fact that given the plethora of these various targetable mutations, and particularly many of these targeted agents that have pan-cancer indications for markers that are present in multiple tumor types, really providing a rationale for genomic testing of all solid tumors, to particularly identify the NTRKs, the RET fusions, the PIK3CA mutated tumors, so on and so forth. So a pathway, obviously, that's gotten a lot of press lately is the PI3K-AKT-mTOR pathway. Many, again, are going to be familiar with this pathway. As we look at C-Bioportal, this pathway is altered in a large proportion of breast cancers, particularly in ER-positive disease with PIK3CA, and then when triple-negative disease, more AKT and PTEN. As many of you know, gain-of-function alterations at PI3K drive cancer cell survival and proliferation, as well as more rare mutations at AKT, where PTEN acts as a brake in being able to shut down the PI3K AKT pathway. Now, until just a few weeks ago, there was really only a single drug FDA approved, which was alpelisib for PIK3CA mutated hormone receptor positive breast cancer. But very recently, we had the approval of the first AKT inhibitor, capivasertib, in combination with fulvestrant for breast cancer. This is based off data from the Capitello 291 trial, as many of you again are familiar, where patients, particularly in those who are PI3K, AKT, or PTEN altered, had a better and significant improvement in progression-free survival compared to those with the use of capivasertib compared to placebo plus fulvestrant. So in those patients treated with an AKT plus fulvestrant had a PFS of 7.3 months versus 3.1 months in patients treated with placebo plus fulvestrant. The reason why I want to highlight this is I think this is a beautiful new example of targeting a pathway. So capivasertib is actually an AKT inhibitor. AKT itself is not mutated very often. It's a relatively rare mutation. It does have gain-of-function alterations, but this drug is actually active in patients who have mutations across the pathway, whether that's PI3K, PTEN, or AKT itself. And again, is a great example of targeting a pathway. We also know that there's a phenomenal emergence of a variety of antibody-drug conjugates and targets. I show just a subset of these. We've seen new drugs against HER3, LIV1, CEACAM5, FDA approvals for antibody-drug conjugates against Nectin-4 and bladder cancer, folate receptor alpha recently, tissue factor in cervical cancer, and others. And what you're seeing in the pipelines of many academics, biotechs, and pharma is a huge amount of proliferation of novel antibody-drug conjugates. Now, we know in breast cancer, we've got a couple of fantastic FDA-approved drugs with trastuzumab deruxtecan in HER2-positive and HER2-low disease, as well as sacituzumab govitecan in breast cancer. But what we also know is we have the emergence of some fantastic novel ADCs coming down the pipe. First of all, I want to highlight Dato-DXd, a TROP2 deruxtecan molecule. We saw some great data this morning from Aditya Bardia, giving us updated data on the TROPION-Breast01 trial. But I think really, again, solidifies the fantastic efficacy that we're seeing of these ADCs targeting TROP2, now with a different payload with Dato versus sacituzumab, showing great clinical efficacy across in different breast cancer subtypes. We also have an emergence of a novel HER3 antibody-drug conjugate, patritumab deruxtecan here. Again, it's very similar ADC in that it has a deruxtecan payload, which is an irinotecan derivative that we know is quite potent in killing cancer cells. Here, ligated to an anti-HER3 antibody, and early data that we've seen on this particular agent is demonstrating beneficial activity in HR-positive, HER2-negative, and triple-negative breast cancer subtypes. Again, we'll be excited for a variety of these novel ADCs to continue to progress through the clinic. We also have a variety of early phase trials of different small molecules. I could not, this talk would go for 3 hours if I highlighted every single pathway and targetable agent. I just want to highlight some that I thought were pretty cool. One, obviously, agents targeting P53 mutated tumors, a very elusive target, as everyone knows. Here, AMG 615, a KIF18A inhibitor, focused on the synthetic lethality in kinetochore proteins along with tumors that are P53 mutated, as well as an MCL1 inhibitor, which we know is frequently amplified in triple-negative breast cancer and overexpressed and associated with inferior prognosis in breast cancer. So I want to now touch a bit on liquid biopsies and clonal hematopoiesis. And again, this group is going to be very familiar with the concept of liquid biopsy, being able to take a very simple blood draw, use highly sensitive next-generation sequencing techniques, and identify tumor-derived material in the circulation. Now, we know liquid biopsies is really a conglomerate of a variety of tumor-derived materials. This can be circulating tumor DNA that's shed from tumor cells. It could be circulating tumor RNA that comes either from the cells or more prominently in extracellular vesicles, tumor-educated platelets, as well as circulating tumor cells. But when we talk about liquid biopsy, in general, we're talking circulating tumor DNA. So these terms are used equivalently. Now, we know the use of liquid biopsy spans the spectrum of clinical care. Obviously, its mainstay use has been for therapy selection in patients with advanced or metastatic disease. But what we've seen over the last couple of years is a matriculation of this technology to earlier disease courses, and particularly in the minimal residual disease setting for patients who've completed curative intent therapy for early stage disease, as well as for early detection of cancer. And what we know is that from a pathway targeting approach, there are a variety of markers that the FDA has approved that when detected by liquid biopsy can be then assigned to a particular targeted agent. I show the list of currently approved drugs and the targets, pathways that they target, and as you can imagine, more and more will be coming down the pipe. Now, in breast cancer, ctDNA obviously has a very powerful story, and some early data published by Sarah Jane Dawson and Dan Stover first demonstrated that the use of ctDNA levels is highly prognostic, i.e. the higher the tumor fraction we observe in the liquid, the poorer the prognosis of these breast cancer patients. And this makes sense. ctDNA levels are generally proportional to the disease burden, and so if your ctDNA levels are high, you typically have higher disease burden, and unfortunately that leads to inferior outcomes. But what we also know is that these mutations are predictive of therapeutic response, and we've had multiple trials that have demonstrated this. One, I think, great example is Nick Turner's plasma match study, that when mutations were identified in plasma and then those patients treated with those targeted therapies elicited fantastic response rates. But one thing I want to really highlight, and one of the major difficulties that we observe in liquid biopsies is this issue of clonal hematopoiesis, also commonly known as CHIP mutations, clonal hematopoiesis of indeterminate potential. So CHIP mutations are somatic mutations, but they're not from the tumor. They're from our white blood cells. And what we know is that these mutations accumulate in white blood cells and increase with age, smoking, and prior chemotherapy exposure. And what this can do is that it can unfortunately be a source of quote-unquote false positives when we're interrogating the plasma trying to identify targetable mutations for therapy. Actually, a fantastic paper by Dr. Pedro Merzavi and my colleague, Dr. Reis-Filho, published in Nature Medicine, I think highlighted this beautifully in 2019, that if you use ultra-high-depth sequencing in the plasma, in the Buffy code of patients, you're going to identify a significant proportion of patients who have these CHIP alterations. Now, thankfully, the majority of the time, these CHIP alterations don't cause a spurious therapeutic association because they're commonly present in genes that don't have necessarily an association with the targeted therapy that you would use in a solid tumor. However, we know in certain situations they can. So this was a great paper published in JAMA Oncology a couple of years ago from our colleagues in the prostate cancer world, where 10% of men with advanced prostate cancer had CHIP interference in plasma that would have led to inappropriate use of a PARP inhibitor. And the reason being is that a common CHIP gene is BRCA, in particular ATM. And so in this particular study, the authors concluded that clinical cfDNA testing should include a whole blood control to correct for these CHIP variants. I want to show you just a little bit of some of our internal data. This is actually very high-depth white blood cell sequencing in about 1,800 cases that we sequence in Caris. And what you can see is that we observe CHIP in about 29.2% of our patients. And the top CHIP genes are ones that you'd expect, genes like DNMT3A, TET2, P53, and others, but I want to highlight the prevalence of BRCA2 and ATM CHIP alterations. Again, these are not tumor-derived alterations, these are white blood cell-derived alterations that in this situation could lead to, if you didn't know the differentiation that was from the white blood cell layer, could lead to inappropriate use of a PARP inhibitor. As I like to tell folks, obviously with liquid biopsies, we want to be able to identify the right therapy for a patient. The last thing we want to do is give them the wrong therapy because we're not getting the right mutation from the proper component. So again, I think as we think about targeting pathways and we're using liquid biopsies, we need to continue to think about the emergence of these clonal hematopoiesis interference. Now, if I went down the list, you'd see actually some more common oncogenes that are closer to home, genes like BRAF, KRAS, PIK3CA, and others that can be infrequently mutated as well, but are actually of CHIP origin. Now, with liquid biopsies, one of the really neat applications of liquid biopsies is for the detection of resistance alterations. And I want to touch on a couple here. So first of all, I think one that's near and dear to everyone's heart and here is ESR1 mutations. We know that these commonly occur in patients who have been exposed to endocrine therapy. They come in two major flavors. The first most common flavor is the actual point mutations. These are in particular domains that cause activation of the ESR1 alteration, particularly ligand binding domain and activation function. We also know that they can, another mechanism of resistance as well is for ESR1 fusions. So these are much less common, about 3 to 5% of hormone receptive positive breast cancer, but similarly lead to a constitutive activation of ESR1. Now, what's been really interesting with the story of detection of ESR1 mutations is that they're actually preferentially detected by liquid biopsy. You more often find ESR1 mutations when you perform a liquid biopsy versus tissue sampling. And it kind of makes sense. We know that these mutations are typically acquired, they're typically subclonal, and a tissue biopsy is just a single snapshot. However, when you do a liquid biopsy, you're picking up ctDNA that is shedding from a variety of tumors. For example, in patients with multifocal metastatic disease, the circulation acts like a sink. So these mutations are shed from these different lesions, and then one can take a liquid biopsy and be able to detect ctDNA that's emanating from these different lesions. So again, it makes sense why a liquid biopsy would be more likely to pick up a resistance alteration. And what we have is I show here 3 publications, but there are more that all have shown that either by liquid biopsy or by use of CTCs, you have a much higher prevalence of detecting these ESR1 alterations. And as we know, if we go after these ESR1 alterations that we detect on liquid biopsy using drugs like elacestrant, from data from the Emerald trial, we can elicit meaningful clinical responses in treating these patients with these targeted therapies. I think another great example comes from Dan Urich's lab. This was just published in Cancer Discovery, I think just a month ago or so, where they looked at acquired resistance to PI3K alpha inhibitors, both alpelisib and inavolisib. The mutational profile here is patients who were treated with a PI3K alpha specific inhibitor and then had liquid biopsies performed. But what I want to highlight in the red box is just the plethora of acquired PIK3CA mutations detected on liquid biopsy for these patients treated with this agent. And again, this theme has been replicated in multiple pathways across multiple trials that, again, liquid biopsy picks up these acquired alterations. Now, what's going to be interesting, similar to the ESR1 story, is what is going to be the next therapeutic avenue for these patients with these acquired alterations and how we're going to be able to therapeutically target these. So I want to end off on digital pathology AI, and it's an area where I'm very bullish and excited about. And if someone asks me and goes, you know, Milan, what do you think is going to be the technology that's going to be the archetype of 2024? I think it's going to be digital pathology AI. So when we look at I actually have to be careful. I'm in front of pathologists. But when you look at H&E, obviously we traditionally used it for cancer diagnosis, for immunohistochemistry, and other clinical features. But when a computer looks at a scanned image, it just sees so much. It sees different features based on texture, shape, color, spatial dynamics. It can see that there's a immune cell that's within 10 nanometers of a tumor cell, or a endothelial cell which is nearby a neutrophil or whatnot. And when you scan these images and you run them through AI algorithms, what they'll do is they'll begin to calculate all these different statistical metrics and extract what are called non-random features, or also human interpretable features, or HIFs. Again, this is just some data that we produce internally. For every scanned image that of every patient sequence, we extract about 63,000 of these HIFs. Now, one of the base layer use cases of what one can do with these HIFs and digital path AI is the computer can tell you, okay, what cell type does it see on a particular image? So, this cell is a neutrophil, this cell is a macrophage, this cell is cancer epithelium, so on and so forth. And this is really a kind of a base level use case, being able to adjudicate the different cell types within a particular image. And maybe, a simple use case of this would be, for example, an automated microdissection instrument that wants to take out the tumor cell section while getting rid of the normal section. So this is easy. Where things, for me, get super exciting is the ability of these algorithms to actually predict the mutational underpinning of a tumor with absolutely no sequencing. And I remember when the first papers came out on this a few years ago. Frankly, I first thought it was just alchemy and black magic. But as you got into it, it's just been unbelievable how powerful these algorithms can be in predicting these alterations. This is actually some internal data on the AUCs of various alterations that can be detected using this digital pathology AI approach. AUC of 0.9 for MSI and CRC, 0.89 for P53 and ovarian to highlight. One that I really like is extremely rare alterations. So here, NRG1 fusions at an AUC of 0.84 in non-small cell lung cancer, and it goes on and on. And I think there's really 3 really interesting use cases for this technology. I think the first interesting use case is the ability to identify patients who have rare biomarkers. So if you have a biomarker that's present at 0.1% of the population, maybe instead of sequencing 1,000 patients to find one, you can sift through a whole bunch of H&Es to identify these patients rapidly for clinical trials. I think a second use case is for low resource settings, maybe in areas where there's not a next-gen sequencing infrastructure. What's really neat about this technology is that it's amenable to various scanning instruments. We actually have been testing even the use of our iPhone linked with a microscopic attachment to be able to do the scans effectively, upload it to an Amazon server and get an answer in 20 minutes. I think it really provides the ability, a potential to democratize precision medicine, in particular low resource settings. But then the third use case is probably the one I'm the most excited about, which is, when you put this digital pathology image through an AI algorithm, the computer doesn't actually know that it's BRAF mutated or PIK3CA mutated. What it sees is something in the morphology that's indicative of an activated pathway. It sees something that says, you know what, there's something here, there's a pattern suggestive of a BRAF mutation or an NRG1 fusion or an NTRK alteration. Well, what that engenders is that you actually have a phenotypic readout. And what we know is that genotype doesn't always equal phenotype. So when I talk to my own scientists, I obviously want to maximize the sensitivity, get the best AUC. But to be honest with you, I'm actually the most fascinated in the ones where the algorithm can't pick up. Because I sometimes wonder, I'm like, are those the non-responders? Are those the situation where you have a mutation that does not result in a phenotypic change on a biological readout like an H&E, and thus when treated with therapies that target this, these patients don't respond as well. So I think that, again, 2024 will be a very, very exciting year in this space as it begins to evolve, not just for mutation identification, but also for therapeutic prediction, recurrence prediction, and other applications in the precision medicine space. Now, the mathematics behind AI continues to evolve. I am not a mathematician, so please don't ask me any mathematics questions at the panel. But what we know is this whole field obviously has gotten a lot of attention. And one of the kind of newest evolution in digital path AI is the application of multiple instance learning. So multiple instance learning is not a new machine learning method. It's been around for a while, but its application to digital pathology is relatively new. This paper published earlier in April of this year took a next level approach to doing digital path. So just to put it simply, when you put one of these path images through an AI algorithm, you're putting what's called the whole slide image. You're putting the totality of what is scanned so that the computer can then learn and determine the genotype or phenotype of interest. What we do with multiple instance learning is it actually cuts these images into various parts. And why this is important is that when you think about it, not every cell within that slide is going to be BRAF mutated. It's going to be infiltrated with stroma, it's going to be infiltrated with immune cells and whatnot. And so what you do in the multiple instance learning is you separate these things into various tiles, what they call instances, and then the computer trains on these various tiles, and it begins to learn and differentiate between what you were expecting as a label and what you don't, and then eventually it brings it back together, concatenates it to get it to a final answer. So what we'll do is it will say at the end, okay, this patient has cancer, or this patient has a particular mutation, but do a much, much better job at differentiating by able to focus on those features and subsets of the data to identify the particular phenotype. So I just want to show some data. So what we have here is some comparison of using standard human interpretable feature AUCs in blue versus multiple instance learning in orange for a variety of different phenotypes. So at the top are EGFR mutations, NRAS mutations, PTEN, NTRK, BRCA1, IDH, and so on and so forth. And what you can see with the application of multiple instance learning, we're actually able to significantly improve the AUC using more novel mathematics behind these algorithms compared to human interpretable features. Suffice it to say, I think the mathematics are going to continue better. Some of you who have kids in high school or using ChatGPT, you understand that personally. But these mathematics are, for its application of digital path AI, will continue to get better, and we'll be excited for what comes down the pipe. So in summary, I really believe we're in a period of unprecedented growth in precision oncology with the emergence of many new pathways and technologies to target them. Obviously, I can't go over all of it in such a short time, but new technologies such as ADCs, liquid biopsies, and digital pathology are going to continue to revolutionize our field. We're seeing a fantastic emergence of novel targets in breast cancer, particularly cell surface targets and synthetic lethal targets that will continue to shape the upcoming landscape. Liquid biopsy will continue to become more and more dominant, obviously for therapy selection, identification of resistance mutations, but also, as I mentioned, its more broader use for MRD as well as early detection. Importantly, I think is going to be this issue of clonal hematopoiesis and being able to understand the implications there. I spoke specifically and more directly to its issue of interference for targeted therapy, but what we know is that it's got other fantastic applications. For example, predicting which patients may develop a secondary leukemia. It's got, as we know, well-known associations with cardiovascular disease, neurological disease, and others. So again, the days are early in interrogating this type of information. And then lastly, AI-driven digital pathology really showing promising results across cancers to identify targets and provide therapeutic insights, again, from a simple H&E and a cloud server. So with that, I thank you for your kind attention, and we'll look forward to questions later.
Thank you very much, Dr. Radovich. Next, we are going to turn to Dr. Ben O'Leary, who's joining us from Royal Marsden Hospital in London, UK. And he will be continuing this theme by talking about tumor tissue versus ctDNA. Thank you.
Hello, everyone. Thank you very much, Dr. Henry, for the introduction, and thank you very much to the meeting organizers for the invitation to speak. So, you've heard a bit already from Dr. Radovich about circulating tumor DNA, and that's a useful introduction, and he's also covered clonal hematopoiesis, which is a key idea when we're making this comparison between the genomic readout that we get from tumor profiling and circulating tumor DNA. What I'm going to do in this talk is drill down a bit more into the tumor-focused element of that in terms of the genomic assessment of the tumor and the differences that you get between tumor and circulating tumor DNA. These are my disclosures. So I'll begin by going into a bit more detail in how we assess circulating tumor DNA, and I'm going to use that to hopefully give you a framework within which you can make a meaningful comparison between the data that you get from tumor profiling and circulating tumor DNA and the reasons why they might be different and the context in which that's the case. I'm going to bring out what I think are probably the most important biological and technical factors, and then I'll finish up the talk by giving some examples where there's some exciting applications coming down the line which really are ctDNA specific. So if you're going to get to grips with circulating tumor DNA, you need to have some kind of familiarity with cell-free DNA, which is what you're actually testing when you're looking for ctDNA. So what you're looking at here is a size distribution plot looking at the length of the DNA fragments that have been extracted from the plasma of 17 healthy subjects. And I think there are two things that immediately leap out to you when you look at this plot. The first is that this is 17 different curves overlaid on top of each other, and you can see they're very, very tightly aligned, showing really quite conserved physiology there. The other thing that you see is this very large modal peak at around 167 base pairs, and the reason you see that peak is because of the physiology of the way DNA is packed into cells. If you recall, it's wrapped around nucleosomes and packed very tightly in the chromatin, and we think that when this is released into the circulation, the exposed DNA, that is the DNA which isn't so tightly wrapped around the nucleosomes, is exposed to endonucleases and cleaved, and this is why you see this characteristic profile with a peak at 167 base pairs, because this is the length of DNA which is wrapped around one nucleosome plus a little bit extra for the linker. And then to the right of that, you can see this slightly smaller peak related to two nucleosomes together. So when you analyze your cell-free DNA, how do you know which bits are tumor? And the key thing here that you're doing is you're trying to look for differences, right, in terms of the genomic changes that are unique to the tumor. And classically, these are all of the things that we know to be associated with cancer: mutations, copy number, structural variants, and methylation. But with circulating tumor DNA, recently it's been understood that there's this additional aspect that you can consider around fragment length. And so if you look at the plot on the right, That blue curve is the composite curve of all of those healthy cell-free DNAs that I showed you on the last slide, and overlaid on that now is the fragment profile from a patient with colorectal cancer. And you can see there are some striking differences in the profile. There's a less pronounced modal peak, and there's this general leftward shift that you see. This is a colorectal cancer example, but this has been seen in lots of different cancers, and the physiology of this still isn't really understood, but it potentially is another place to find a lever to discriminate between cancer and non-cancer, and further, there's other biology that potentially we can derive from this as well, which I'll go into in a bit. So I think the key difference is just in terms of keeping it broad and simple here, in terms of the readout that you get from tumor genomics and ctDNA can be separated into biological and technical factors, and the biological factor that you really want to consider when looking at these genomic changes that you find in cancers is the differences between tumor and cell-free DNA in terms of clonal heterogeneity and representation of disease. So that's the difference between sampling with a needle, a small part of a tumor, and then assaying DNA that's been taken from the circulation that may have a contribution from, indeed, many parts of a particular tumor, or in the metastatic setting, different sites of metastatic disease. I've mentioned fragment length, and actually you don't get this at all when you profile tumors, and that's because it's intrinsically related to cell-free DNA and circulating tumor DNA, so potentially some opportunities there. So the last thing to say is a really important factor when you're considering what you get out of a circulating tumor DNA assay is this idea of tumor purity and how that can affect the readout. When we assess for circulating tumor DNA, we take cell-free DNA, which we've extracted from the plasma of patients, and then we look for these changes, for these genomic aberrations. And if you're only looking for a couple of things and you know what they are, a reasonable approach is to use digital PCR. But if you're looking for more than a handful of changes, you're going to have to use a sequencing approach. Now, you can go straight in and do whole genome sequencing on cell-free DNA, and that's fine, but it is extremely resource intensive. And so more conventionally, if you've got a more focused question or things that you know you're looking for, you can perform this step on the DNA of target enrichment, which is where you go through a workflow which focuses your analysis on the areas of the genome which you are most interested in. And this can be done in a tumor agnostic way. That is, you can choose things that you know to be prevalent in your cancer of interest, or you can do it in a tumor-informed way, and this is what's commonly used in the minimal residual disease paradigm. You have a tumor that you've profiled, and then you can create an individual assay for that tumor. Now, when you do the sequencing on that, what you get out is precisely that, sequences, right, of strings of A, G, Cs, and Ts, and you line them up against a reference. You can see that down here on the bottom. The grey, these are all the sequencing reads that are lined up. The grey means that it's the same as the reference, and you can see you're looking for these changes here. So there's a T where there should be a C. So if these are the raw data, this is what it looks like when you do your circulating tumor DNA sequencing. What are the data that we get from these? So the first thing is variant detection. You can do a comparison along different areas of the genome and identify mutations, structural variants, and methylation. There are various parts of DNA, the processing workflow that you can use to identify methylation with enzymatic workflows or classically bisulfite sequencing. The next thing that you get is the proportion. So you can look at the proportion and the amount that you get of the variant alleles and the reference alleles, and this is what allows you to start quantifying those aberrations and assessing copy number. And the last thing that you can get is this fragment distribution. And again, as I've mentioned, this isn't something that you can get from tumors. When you do the short read sequencing on tumors, you have to cleave the DNA into short fragments. It happens in a stereotyped way. Whereas in this fragmentation pattern, there's inherent biology potentially, and inferring transcription, which I'll come on to in a second. So I want to persuade you of the importance of considering tumor purity when you're making a comparison between readouts between the tumor and the plasma. And to do that, I've just got this cartoon here where you can see a normal cell. This is a normal cell that has 2 copies of a particular gene, and in a cancer cell, 1 copy of that gene has been lost, and then the remaining copy has been mutated. And of course, this is a common situation that you see in cancers with tumor suppressor genes, such as TP53 or P10. So if you're looking at a tumor assay, you get your friendly collaborating pathologist to help you identify a section of the tumor which is enriched for tumor cells, and you can see you have plenty of the red allele here to pick up. But also, actually, if you have enough tumor cells in here, you can even detect that the proportion of grey alleles is perhaps less than you would expect and detect losses. This is completely different in cell-free DNA. You have absolutely no control over the tumor content of those samples, and it can vary widely and is usually very low. You can see it's actually the technology that's hugely increased the sensitivity of what you can pick up here. That means you can still pick up these variants, but I hope I can persuade you that if this is one tumor cell, it's very difficult to infer the absence of one particular grey allele there in that big mess. So what does the tumor content look like in a metastatic breast cancer context? So these are some data that we generated in the Paloma-3 trial. This is about 400 patients with metastatic ER-positive breast cancer. And on the y-axis here, you can see the tumor fraction. And what you can observe is that around a third of patients have a tumor content in their plasma which is greater than 10%, which is, that is very low for a tumor assay, and it only gets lower as you move to the right. This is the shoulder of the assay detection. So I want you to remember that 10% threshold, because I'm going to come back to it later. It's worth considering structural variants separately, and they're an interesting case in terms of comparison between tumor DNA and ctDNA. So often I'm going to use as an example here, this is gene A and gene B, where you've got the exons here in the more brightly colored areas and the introns in the kind of more drably colored areas, which are rather larger. And the fusion gene product occurs when there's a break, which can often be in intronic areas and often be unpredictable. So if you don't know where this is, you could take a whole genome sequencing approach and try and find it in a low content sample. That would be challenging. And most of the target enrichment strategies are usually focused around the exonic regions. This makes a lot of sense. This is where a lot of the action is in cancers. But if you want to find that breakpoint and you don't know where it is already, it's going to be difficult. An interesting example, turning that logic slightly on its head, is that if you do know where the fusion is, where the breakpoint is, it becomes an excellent target to track in the minimal residual disease setting. So if you've identified structural variants in the tumor beforehand, it's something that actually you can use to exploit, because they can be excellent targets, because they are essentially quite a bizarre structure where one bit maps to one gene and the other bit maps to the other gene. You have a breakpoint across the middle. So I've highlighted the difference in the overall fragmentation pattern to you, but you can go one further using this concept of nucleosomal occupancy. And what do I mean by that? This is an idea that comes back to this, the point that I made earlier about cell-free DNA, where you thinking about how the DNA is wound around the nucleosomes. So normally when transcription is occurring, this has to be unwound. And so you can look in cell-free DNA and find missing areas where this exposed DNA has been cleaved. And looking across the whole genome, you can infer, in fact, transcriptional programs. And there's a nice example here from Gavin Haar's group. You can see this classifier between ER-positive and ER-negative breast cancer patients. This is on the basis of whole genome sequencing in the plasma. And you can see here that the group that is performing really well, the model's performing really well in the blue curve, is this group down here. What's special about that group? It's the tumor fraction above 10%. And remember, I showed you in the Paloma-3 data, that's a relative minority of patients. So to do these things, sometimes it's going to be a struggle in terms of how much actual tumor you have in your sample. So I've shown you can put lots of different things, look for lots of different things in your circulating tumor DNA assay, and it depends what you're asking. It's always the reasonable answer to what test should I do is what is your question. But this is also for paradigms where the question is there cancer or not. Increasingly, it's a valid approach is to use as much of this as you possibly can to generate a binary cancer present, cancer absent signal in the, for example, the tumor-free scenarios of screening or minimal residual disease. So we've got an increasing list of genomic targets in breast cancer, and I've taken these from the ESMO guidelines. I've just updated slightly with the Capitello 291 results. And I'm not going to talk about the therapeutic implications of these so much because you've got Dr. Reis-Filho following. But what I'd like you to consider is that when you're assessing these genes for the changes that commonly occur in them, you're looking for quite different things, right? So some of these genes have very stereotyped hotspots. Other tumor suppressor genes have mutations that are less well stereotyped across them. copy number gain, copy number loss, and structural variants. So it's useful to have some kind of understanding of how all of these things are separately assessed in the cell-free DNA and affected by tumor purity. So you've seen one of these waterfall plots already in Dr. Radovich's talk, but how can we use ctDNA to allocate targeted therapy? This is from the Plasma Match study, which is a large UK-wide study that was led by Nick Turner, about 1,000 patients. And the principle being tested here was whether or not you, instead of tumor profiling, you could use a plasma-first approach, identify a change, and allocate a targeted treatment. It's a platform multi-arm phase 2. You can see from the two waterfall plots here, we've got neratinib being given to patients with ERBB2 mutation on the left, and capivasertib being given to AKT1 mutations on the right. Patients with AKT1 mutations in their plasma, and some really encouraging data there, proof of principle, and increasingly we're seeing trials along these lines. So the other major thing that I flagged at the top of the talk in terms of considering differences between the way you might assess the tumor DNA in either the cell-free element or the tumor itself is heterogeneity. And I just want you to think about this kind of scenario where a patient is treated for an ER-positive breast cancer, historically with surgery, radiotherapy, and an aromatase inhibitor, then subsequently, unfortunately, relapses both locally and then in the liver, lung, and bone. And in the lung metastasis, we have an evolved ESR1 mutation, D538G, in relation to the aromatase inhibitor therapy. And in the bone metastasis in the left femur here, we have an ESR1 Y537S mutation. So if we use a needle biopsy for the liver, or indeed the local recurrence area, then we would return an ESR1 wild-type genomic result. Whereas if we assay the plasma, there's a greater chance for contribution from the ESR1 mutant alleles at these two metastases at picking up one or both of them. This, of course, these mutations, we know that they arise in response to aromatase inhibitors, but you won't know where they arise or which metastasis they're going to arise in, and they arise in a subclonal fashion and sometimes in a polyclonal fashion in patients as well. So there's a clear steer here that potentially plasma is the better assessment modality in this setting. Having sold you the idea that plasma is better in this context, it's important to acknowledge that there's a fair degree of uncertainty over what you're actually getting in the plasma when you measure the mutations in ctDNA. And this can be essentially has a number of factors contributing to it. And the data on this aren't particularly strong, to be honest, but they're more based on looking at kind of like whole tumor results. But you see bigger tumors, you get more ctDNA, proliferation appears to be related, as well as potentially anatomical site, which may vary between cancers, but there's probably, I would say, a clear signal that CNS disease is less well represented. Another thing to consider here is the clonal representation within the plasma. So if you're looking for mutations that are in the trunk here of the cancer, then they're going to be more prevalent, they're going to be easier to find in this red envelope versus the smaller subclonal mutations found in the green and the blue populations with the ESR1 mutations. So this idea of testing for molecular progression was looked at in the PADA-1 trial, and this was a 1,000-patient study in France, and they enrolled patients with ER-positive metastatic breast cancer who were being treated with an aromatase inhibitor and palbociclib. And they monitored, using digital PCR, they monitored for ESR1 mutations, and when they noted a rise in ESR1 mutations but didn't identify any clinical progression, they randomized patients to either continue on their treatment, they didn't have clinical progression, they had molecular progression, or to switch the endocrine part of their treatment to fulvestrant, which is an agent that we know to have some activity in ESR1 mutations. And this trial was positive, showing an improvement in progression-free survival, and it's an interesting proof of principle study in terms of treating on molecular progression rather than clinical progression, and we're going to see more trials like this going forward. So another area where I think there's a lot of potential for ctDNA, where tumor is not really an option, is in the early monitoring of response to therapy. So we want to do personalized medicine and we want treatment to be personalized, but potentially doing a trial of a therapy in a person is about as personalized as it gets if you can get an early readout on how they're going to do. So these are data from our original analysis of the Paloma-3 trial. This is where these are patients who were being treated with palbociclib and fulvestrant, and we assessed their circulating tumor DNA at day 1 and day 15. We were using a digital PCR assay directed against PIK3CA mutations, and you can see overall there's a downward trend between day 1 and day 15. But actually, what we found was that you could separate the population of patients on the basis of how much their ctDNA came down relative to how much there was at the start of treatment, and use that to, and that was associated with how well the patients did subsequently. So the red line on the Kaplan-Meier plot here is patients in whom their ctDNA level didn't drop so much. So this is an effect that's now been observed in lots of different cancers with lots of different treatments, and so there are a number of different trials looking at how this might be integrated into experimentally finding new approaches for treatment. And this is a trial which is open at our centre and is led by my colleague at the Royal Marsden, Alicia O'Kines. And so patients with, who are receiving CDK4/6 inhibitor and fulvestrant are screened for circulating tumour DNA and then examined in that day 1 to day 15 window, and if the ctDNA doesn't go down enough beyond a threshold, then they enter this randomization towards treatment escalation with an inclusion of another agent, ipatasertib, an AKT inhibitor in this case. The last indication potentially that I'd like to mention is in the neoadjuvant setting, which I think is really interesting, and you might think, well, you know, what's the point in that? We're going to have the tumor anyway, and we've got a really nice paradigm in terms of risk stratifying for patients who are going through the neoadjuvant paradigm in terms of the residual cancer burden in the tumor. So these are some recently published data from the I-SPY2 investigators, I-SPY2 being a platform trial with looking at experimental combinations of neoadjuvant treatment for breast cancer. So alongside that clinical workflow, they also have a translational work stream where they're collecting plasma at different time points. And if you can focus on the T3 time point here, this is the time point that's just before the surgery. So what's the point of doing circulating tumor DNA when you're about to do the surgery anyway, and you're going to get the readout in terms of the residual cancer burden? So what the investigators found here is that this is a Kaplan-Meier plot showing the risk of relapse. If you look at the difference between the green line and the red line, these are both groups, if you look at the risk table, these are both groups with the same RCB status, groups 2 to 3, okay? And the green line shows the patients who are ctDNA negative at that time point, and the red line shows patients who are ctDNA positive, and so they're doing worse. This is these are patients who have the same findings on surgery in terms of their residual cancer burden. And so a really interesting idea there that potentially ctDNA could complement additional information along with the tumor profiling. So in summary, circulating tumor DNA is much more accessible than tumor tissue. It's easier to do, it's more tolerable for the patients, and it's safer. So if you can do it, and there's a good evidence base for doing it, it's definitely something to pursue. There's almost certainly greater subclonal representation that you're going to get, although there's some uncertainty over exactly what it is that you're getting in terms of the representation within your plasma assay. But because of that, I think there's a strong rationale for favoring it for when you're looking for emergent genomic mechanisms of resistance, because these will inevitably arise subclonally, and you would risk missing them, or at least you optimize your chances of catching them if you use a plasma approach. And so I've talked about ESR1 mutations, but increasingly there are other indications for this as well. Interestingly, potentially BRCA1 and 2, as we find that revertant mutations are an emergent mechanism of resistance to PARP inhibitors. In addition to all of that, we have the fragmentomics that potentially offers independent and complementary biology alongside tumor biopsy, and through nucleosomal occupancy approaches, we can potentially look at transcriptional programs at the DNA level in the plasma. So I think that's a really exciting field, and we're going to be seeing more and more coming through on that. There was a really nice presentation on that in the ctDNA session yesterday, looking at potentially whether or not you could do a version of that just by looking at the fragmentomics of exon 1 in ESR1. So it's really interesting work. And finally, and importantly, we need more interventional trials to show clinical utility of those approaches. And what we want is to be able to do these tests in confidence that they're making a difference and having a real clinical impact. And the only way to do that is with interventional ctDNA-based clinical trials. Just to finish up with the last couple of comments about tumors, I've kept the discussion very focused on the DNA in tumors and the comparison between DNA profiling in tumors and DNA profiling in the plasma, but tumor assessment remains the gold standard for a lot of the evidence base that we have to inform practice. So if you're going to use a ctDNA test, you need to be confident that you have the evidence base to do it. Tumors, of course, provide a lot more than DNA. They give you microenvironment information and cell morphology, and it's potentially, those things are a goldmine for translational and biological discovery work, and we'll continue to rely on tumors for that. Last thing to say is that from the tumor perspective, they definitely are better than ctDNA for copy number and structural variant discovery, although there is this interesting paradigm that I took you through in terms of when you know what the structural variants are, they're a very attractive target to chase in the plasma for the minimal residual disease paradigm. So just to finish by thanking the patients, carers, and families of the study participants who took part in the studies that were involved in the data that I showed you from our group, and the collaborators who contributed to that, and also to the funders who funded the work. And thank you very much for your attention. Much obliged.
Thank you very much, Dr. O'Leary. And so now for our third educational talk, we are going to hear from Dr. Jorge Reis-Filho from AstraZeneca, and he is going to talk about when do you order and how to interpret genomic testing. Thank you.
Thank you so much. It's such a great pleasure to be here today. I'd like to thank the organizers for the kind invitation of discussing with you when do we order and how do we interpret genomic testing in the context of breast cancer. It's also an immense pleasure to be here back in San Antonio for the first time as a member of AstraZeneca. But I have to say that this invitation was extended to me when I was still a member of Memorial Sloan Kettering. In any case, these are my conflicts of interest, present and past. And in the next 25 to 30 minutes, what I'd like to do is to recap with you when do we order and how we interpret genomic testing in the context of, first, early breast cancer, and I'm going to do a recap of the genomic signatures and BRCA1, BRCA2 mutations, and then we're going to go into metastatic disease, where I'd like to discuss with you this panoply of biomarkers that actually now require genomic testing for us to render critical decisions. So I think now in 2023, we have all come to terms with the fact that the treatment of a large proportion of patients with early breast cancer can no longer rely only on the clinical pathologic parameters plus ER, PR, and HER2 assessment by immunohistochemistry and or in situ hybridization. As a matter of fact, over the last 20 years, we've seen the development of many biomarkers for breast cancer, and some have actually hit prime time, including the genomic signatures and BRCA1 and BRCA2 mutation assessment. When it comes to the genomic signatures, that started over 20 years ago, actually, with the notion, at that time, we were using microarrays. Yeah, do you remember that, microarrays? Yeah, we used microarrays to identify a population of patients with early stage breast cancer that would have such a good outcome that they could forego chemotherapy. Well, in those 20 years that passed since the first signature, we have come to understand actually that it does work. And there are now 5 commercially available signatures that are supported by level 1 evidence that fit that particular purpose, including Oncotype DX, MammaPrint, EndoPredict, ProSigna, and Breast Cancer Index. So much evidence has accumulated that now we have clear guidelines to help us define how we use these signatures in clinical practice. And ASCO last year provided an update of their guidelines in an excellent paper by Fabrice Andre and collaborators here, where they discussed the utilization of these genomic signatures for patients with early stage breast cancer. And the signatures are only applicable for patients with ER-positive disease. And in the context of premenopausal patients, patients younger than 50 years, the signature that has the strongest evidence and the strongest recommendation here, as you can see in this, if I can get the mouse to work, yeah, here it is, here in node negative, is Oncotype DX. But since the publication of these guidelines, additional information has emerged, for instance, for Prosigna with the soft trial. They're showing that it also has sufficient evidence there, perhaps. Now, for patients who are postmenopausal or older than 50 years, in the context of node-negative disease, all of these signatures here are supported by varying levels of evidence and levels of recommendation, as you can see here in this box. And in the context of node-positive disease, the signatures are indicated only for patients with 1 to 3 lymph nodes. I have to emphasize here that the group from ASCO agreed that there was not sufficient evidence in the context of node-positive disease in premenopausal patients or 4 or more nodes in the context of postmenopausal disease for the use of these signatures in clinical practice. And here is a list of all of them, and you're very familiar, I'm certain, with all of them. 2 are supported by level 1 evidence, MammaPrint and Oncotype DX, because they were supported by prospective clinical trials that were designed to test the value of the signature. And 3 are supported by level 1B evidence, and to predict Prosigna and breast cancer index. Some are delivered as central tests, as local tests. So, and this is important because in different countries, a distributed model may be more efficient. In other countries, a centralized model may be the preference here. And an important point is that if you do what I used to do, that was to scrutinize this list of genes and try to understand them in great detail, you'll see that there is very little overlap between these signatures. However, they do identify subsets of patients that actually do exactly what the signature is supposed to do, identify good versus poor prognosis. What's interesting and that we have come to understand over the years is that these signatures identify as of poor prognosis the patients whose tumors have high expression levels of proliferation-related genes, low expression levels of estrogen-related genes, and differential expression levels of immune-related genes. So it's a combination of that. Importantly, however, we see that there are many different categories for each one of the signatures, and they are not exactly the same. As a matter of fact, if you apply them to individual patients, and we compare the signatures head-to-head, the commercial signatures, like John Bartlett did in the Optima preliminary trial here, comparing Oncotype, MammaPrint, and PUM50. As you can see here, the frequency of low or high risk vary a lot. In the same population of patients, vary a lot from signature to signature. And in fact, when they apply to individual patients and asked what is the agreement for low or high risk for these different signatures when applied to the same patients, the kappa scores ranged from 0.4 to 0.53. So in terms of individual patients, there are differences between these signatures. And one of the reasons for that, one could contend, is that all of these signatures, if you look at here, all of them, including some of the immunohistochemical assays that you use as well, like IC4, they are all very good in terms of detection of early relapses within the first 5 years. And this is what they were developed for to begin with. And this helps us in terms of identifying the patients that have such a good outcome that they could forego chemotherapy. But some of these signatures actually can also identify late relapses that happen after 5 years. And here you can see Oncotype, and then in particular PUM50 and the Predict and Breast Cancer Index. In fact, in a study that used the ATTACK trial material from Mitch Dowsett several years ago, they compared PUM50 with the recurrence score, and they observed here that from 0 to 5 years of follow-up, actually there was equivalence between the signatures. But in the period between 5 to 10 years, PUM50 could be more discriminative in terms of the outcomes than a recurrence score. And these signatures that have this ability of identifying the late relapses perhaps can be used for the prediction of extended endocrine therapy. And in fact, in the ASCO guidelines, the update, they recommended one of these signatures to be used in this particular context. Now, shifting gears and talking about the second reason for us to be sequencing or performing genomic tests in early stage breast cancer, that's BRCA1 and BRCA2 germline mutations. As you know, a substantial proportion of patients with breast cancer have genomic alterations affecting BRCA1 and BRCA2. And these can be germline, can be somatic, it can be even methylation, actually. And why does this matter? Because the beautiful work from my former mentor, Alan Ashworth, and also from Thomas Halliday, back in 2005, demonstrated that BRCA1 and BRCA2 mutations are in a synthetic lethal interaction with PARP inhibition, and the rest is history. Yeah? We've seen what developed first in the context of metastatic disease, with many trials demonstrating that PARP inhibitors provided a significant increase in progression-free survival in patients with BRCA1 and BRCA2 germline mutations. What's really exciting is what my former colleague, Andrew Tutt, published in the Olympia trial, where they tested patients with HER2-negative, high-risk, early-stage breast cancer harboring BRCA1 or BRCA2 germline mutations, and demonstrated that the addition of olaparib resulted in a significant increase in survival in this context here of early breast cancer. And this is, has come to become a reason for us to be surveying germline alterations in breast cancer in a much more systematic manner, for this, at least for this population that is described in the inclusion criteria for the Olympia trial. So in conclusion for this first part of the talk, what tests should one order for early breast cancer patients? I'd say here for BRCA1 and BRCA2 germline mutations, absolutely, and we need to be following at least what I've just said, that is the criteria of the Olympia trial. But in some institutions, like the one I used to work at, we were sequencing all patients with breast cancer because there is value added in understanding here the presence of a germline mutation affecting BRCA1 and BRCA2. In terms of the genomic signatures, I think here, with 5 signatures being available, some performing differently in a specific clinical contexts, I think we have to follow the guidelines. We have to remember that we should deploy the signatures based on availability of the signature and the clinical context of the patient, and we have to use the best evidence available. There's no one-size-fits-all here. Now, moving on to metastatic breast cancer, and this is where those investigators and clinical practitioners who are really interested in precision medicine have witnessed the most phenomenal progress over the last 20 years, to the point that now, if we think about biomarker assessment of metastatic breast cancer in 2023, it's really incredible. We have a panoply of biomarkers that we have to assess in tissue. And it's a ball for people like me, pathologists, because we have a lot to do now. Oh, and we can perhaps move from our basements to higher positions in our institutions, but that's an aspiration. Anyhow, in terms of tissue analysis, when we have a metastatic breast cancer, we need to confirm the ER, PR, and HER2 status, and we have to assess HER2 low as well. In a few contexts, we have to assess PD-L1 expression and also perform the TIL analysis, even if it's only prognostic. And in some contexts, given the cancer agnostic approval of some biomarkers, we can use pathology actually to screen for some alterations, like mismatch repair protein deficiency or NTRK expression, because it's a great screening tool or a useful screening tool for the presence of NTRK fusion genes. And in the context of some trials, even AR assessment. Now, when it comes to DNA, we have now a huge list of tests that we need to perform, and echoing what Milan quoted directly from a paper from Debiani in JCO, there's a reason now for us to entertain sequencing every metastatic breast cancer patient, because there's so many biomarkers that we need to derive. Germline, BRCA1, and BRCA2 mutations, and in addition to some additional HR-related genes like PALB2, somatic genetic profiling with PIK3CA mutations, AKT pathway gene alterations, ESR1 mutations, and HER2 gene mutations as well. And then, of course, the tumor-agnostic biomarkers that we have to survey now, including MSI, TMB, NTRK fusions, and BRAF mutations, even if they are vanishing real bad. And in some contexts now, at least in some studies, mutational signatures are being surveyed likewise. And if we can even have to consider transcriptomics if we are in selected cases, because we can detect the NTRK 1, 2, and 3 rearrangements much more efficiently, and we can detect the RAT fusions, again, more efficiently as well. And this started to change really around 2017, 2018. We had many pieces of data explaining to us the repertoire of somatic genetic alterations in metastatic disease, but 2018 was when everything started really to materialize and to consolidate with 2 seminal papers, one by Fabrice Andre's team, and the other one by Pedro Mrazavi. And here's a figure from Fabrice's paper. It's a really busy slide, but I'd like to talk you through it. In each column is a patient, each row here is a gene. Each tick here is a mutation, color-coded according to the legend here on the right. On the left, in these squares here, we have the gene significantly mutated overall in the cohort and then in specific subtypes. And if you just eyeball the list of genes here that are significantly mutated in metastatic breast cancer, you see that there are some of the usual suspects, yeah? And they should be. They are early drivers. They're like 53, PIK3CA, CDH1, and so on and so forth. But we start seeing new things, things that we're not used to see when we looked at TCGA data or PCOG data, like ESR1 mutations, like NF1, and a few others, RB1. And in fact, a systematic analysis then comparing metastatic breast cancers, MBC, with early breast cancers in Fabrice's paper, or an analysis of the odds ratio of how likely or how enriched a given gene is in terms of mutations in the metastatic versus primary breast cancers, there were some really exciting findings, including here findings that were found across studies, NF1, RB1, but the big outlier was really ESR1. Comparing metastatic breast cancers with primary disease. And this is, of course, in ER-positive disease. ESR1 mutations have been found now to be the main mechanism of resistance to endocrine therapy. They are present in 11 to 48% of ER-positive patients treated with aromatase inhibitors or subjected to estrogen deprivation. They're very rare in primary tumors, less than 3%, more often than not less than 1%. And they affect the ligand binding domain. They are in the form of hotspots. There are some particularities about some of these mutations, but overall, they result in constitutive activation of the estrogen receptor alpha protein. And it's very important because these account for approximately 40 to 45% of resistance to endocrine therapy. However, this is not the whole story. If you look at ER-positive breast cancers, metastatic, resistance to endocrine therapy fall into one of 4 major buckets. ESR1 mutations, then we have MAP kinase-related alterations, then alterations affecting transcription factors, chromatin remodelers, and MYC. And then the 4th group that's shrinking by the week, let's put it this way, is the group of unknowns. And there are still cases for which we cannot understand exactly what the mechanism of resistance to endocrine therapy is. So there's still a reason for us to continue investigating these tumors in a much more systematic manner. But the discovery of the ESR1 mutations that actually happened many, many years ago by Suzanne Fuqua initially, and then discovered and contextualized in a more precise manner by Saracha and Dalapati's group, resulted in a fundamental shift in the way we even perceive these mutations. I was discussing this with Milan earlier, and we are debating, is ESR1 a mutation that causes resistance, or is it a target? Because now, with the results of the Emerald and the SERENA-2 trials, actually, ESR1 mutations are a target because there are new SERDs that actually effectively target patients with metastatic breast cancer post-endocrine therapy that have acquired an ESR1 mutation in a really efficient manner. There's efficacy here. And you can see the results here in terms of the progression-free survival in patients with ESR1 mutation in the Emerald and in SERENA trials, and with a significant advantage in terms of progression-free survival as compared to fulvestrant. So it's really exciting because there is progress, and we've identified as a mechanism of resistance. Now it's a therapeutic target. An important point is that across studies, we have come to understand here that the frequency of these alterations, if we do tissue biopsies, metastatic tissue biopsies, the frequency will be at most around 30%. But if we sequence plasma DNA, it goes up to almost 50% of the patients who progress on aromatase inhibitors. And as Ben alluded to, there are some alterations that perhaps can be best identified using plasma ctDNA sequencing. And in fact, now the recommendation for patients with ER-positive metastatic breast cancer post-endocrine therapy is for us to test upon progression using a liquid biopsy, preferentially. So the other reason for us to be sequencing metastatic breast cancers comes from the result of the SOLAR-1 trial. Again, Fabrice delivered this one, where basically they demonstrated that alpelisib plus fulvestrant actually resulted in a better outcome for patients who are ER-positive, HER2-negative, locally advanced or metastatic, harboring a PIK3CA mutation. It's interesting here that the use of this particular drug, the multi-gene profiling, has been really adopted in terms of how to deliver alpelisib. Now, this area of the PIK3CA alterations, PI3K pathway, AKT pathway, has expanded even further with the Capitello 291 study, where patients treated with aromatase inhibitor who progressed, metastatic breast cancers who progressed on treatment with aromatase inhibitors within 12 or on 12 months, they were randomized to receive fulvestrant plus capivasertib or fulvestrant plus placebo. And there were two endpoints tested in this particular trial, progression-free survival overall, but importantly, progression-free survival in the context of the presence of AKT pathway-altered tumors. And here, what I'm talking about is PIK3CA mutations, AKT1 mutations, and PTEN alterations, mutations or loss. And the results are here, and this has resulted in the approval of capivasertib in this particular population harboring the AKT pathway genetic alterations. As we alluded to prior in the previous talks, there are now cancer-agnostic biomarkers that actually justify the use of genetic sequencing or genomic sequencing for metastatic breast cancer patients. One is in the form of NTRK1, 2, and 3 fusion genes. And for the pathology aficionados here, we have actually in breast cancer a tumor type that's defined by an NTRK fusion that's called secretory carcinoma, where over 95% of the cases harbor an ETV6 NTRK3 fusion gene. But I'm not talking about secretory carcinomas, I'm talking about the metastatic breast cancers that actually have an acquired NTRK1, 2, or 3 fusion. They are rare, they are hard to detect as well, And they have become one of the reasons for us to be performing even RNA sequencing, targeted RNA sequencing in the context of metastatic breast cancer. We have microsatellite instability, as illustrated beautifully in many studies now. Microsatellite instability is rare in breast cancer, 0.8 to 1.7% of the patients, but it's a predictor or is indication for treatment with immune checkpoint blockade, in particular pembro. We have more recently 3 additional cancer-agnostic reasons for us to be sequencing metastatic breast cancer. We have RET fusion genes because their presence is an indication for treatment with RET inhibitors. We have BRAF mutations, which also constitute an indication for a specific treatment here, a combination of dabrafenib and trametinib. But these 2, when we think about breast cancer, and if we even think about the results of sequencing, and Milan can correct me here, we don't think immediately about, for instance, BRAF mutations in breast cancer. They're vanishingly rare. We have to remember, these are really, really rare alterations. And then we have one of the most challenging biomarkers currently, that's tumor mutation burden, which also is a cancer type agnostic biomarker. That's an indication for treatment with immune checkpoint blockade. Pembro here. The cutoff for tumor mutation burden high in breast cancer is 10 mutations per megabase. It's approximately 5% of all breast cancers and across types, but here we have a challenge. If we think about high tumor mutation burden in colorectal or endometrial, the main reasons are microsatellite instability and ultra hypermutated POLE alterations. In breast cancer, that's not the case. In breast cancer, as beautifully illustrated by work by Antonio Mara and Sarat Chandalapati presented at ESMO last year, in breast cancer, the majority of cases with high tumor mutation burden that are highlighted in the pie charts here in green are actually, the high tumor mutation burden is caused by APOBEC mutagenesis. And whether APOBEC mutagenesis results in the formation of the same amount of new antigens or results in the same type of immunity as microsatellite instability or POLE remains to be defined. So, and we have to remember that the trial that resulted in the approval of TMB as a cancer-agnostic biomarker did not include any breast cancers, the first study. So we have to remember that this is an evolving field, and whether the cutoff is spot on at 10 or not remains to be fully defined. Now, when it comes to interpreting these genomic alterations, I would say that there are a few points that are really important. First, to ensure that the assay and the testing are really fit for their purpose, that we followed guidelines, that adequate classification of the genomic alterations based on the actionability of the alterations needs to be performed, and what in my practice in the past in terms of genomic interpretation of genomic reports was to use ASCAT, that is the ESMO classifier of actionability of mutations, or OncoKB. And this information is really useful because it's updated regularly. We have a really objective way of interpreting those alterations. And molecular tumor boards, as discussed here at San Antonio as well, play a pivotal role. It's wonderful to have the multidisciplinary team with us addressing all the different aspects. And what I learned in the molecular tumor boards, to be perfectly honest, is that by having pathologists, genomicists, oncologists, radoncs, radiologists, that a diagnosis or the detection of the genomic alteration and its subsequent classification together, they do not offer a cure, but they are a great place to start, yeah? Because if we start from there, our chances of getting it right increase substantially, let's put it this way. So here is just a list of the ASCAT assessment of molecular targets in breast cancer, and the ones classified as 1A, 2B, and 1C. For the 1A, the alterations that are really targetable here, that's supported by prospective trials, HER2 amplifications, germline BRCA1 and BRCA2 mutations, PIK3CA, AKT1, and PTEN alterations, ESR1 mutations. Those are level 1A. And these are the main reasons for us to be sequencing all metastatic breast cancers. Then we have ERB2 mutations and PALB2 mutations that are level 2B. And all of these cancer-agnostic biomarkers are classified as 1C. But all of them together provide a reason for us to be sequencing these tumors regularly. And we can structure it in different ways depending on the availability of sequencing and availability of resources in our practice. This is one of the ways that I approach it. Receiving the sample, we perform the ER, PR, and HER2 to really ascertain that everything is exactly what it's supposed to be. And then for the sequencing for ER positive or triple negative breast cancers depends upon the levels of evidence provided by SCAT and OncoKB. And then I'm putting this, this framework here, this flow chart today. But I have to say that this evolves so quickly that probably in a couple of weeks it's going to be passé already. So I'm not going to belabor this, but my point here is if we structure the sequencing that we need to do on the basis, for instance, of level 1A, 1B, 1C, 2, and 3, we are really in a good position of prioritizing what needs to be done. Given that multi-gene sequencing now is justified for all metastatic breast cancer patients, both in the recommendations of ASCO and also recommendations of ESMO, we're in a strong position to be doing it. Now we just need the resources, yeah? In any case, I hope I had demonstrated to you in the last 29 minutes that genomic testing has come to become an integral part of the management of breast cancer patients, and several critical decisions about the management of our patients depend upon the results of these tests. That in early breast cancer, we have reasons to analyze those tumors because of the value of the genomic signatures in BRCA1 and BRCA2 mutations, and in metastatic disease, this panoply of markers that I discussed with you. I have to say that as a pathologist and someone really passionate about seeing the lives of our patients improving on the basis of our ability of identifying the right patient at the right time with the right biomarker at the right time in their therapeutic journey, it could not be a better place to be doing this. We have the opportunity of changing lives through the use of our molecular assays and by bringing together pathology, oncology, and this multidisciplinary team. With that, I would like to thank you for your attention. I would happily take any questions you might have. Thank you.
Thank you very much, everybody. So now it's going to be open to questions. I don't know that I can actually see the mics very well, but I'm going to do one that's online first. And it's a practical one, either for Dr. O'Leary or for Dr. Radovich. What is the role of variant allele frequency in the interpretation of genomic tests in metastatic breast cancer? For example, how do you interpret a liquid biopsy if the mutation allele, variant allele frequency is 0.5% or 3% or 15%? And do we actually know that tumors that have a higher variant allele frequency are more likely to benefit compared to those with a low?
So I think that sort of speaks to what, whether we're talking about whether it's in the tumor or in the plasma, if you like. So, I mean, the allele fraction is essentially an expression of how much you count of the variant versus the reference. And so in the context of the plasma, often it's kind of a surrogate for mutation, for burden, for ctDNA burden, which we know to be prognostic in certain settings. Now, in the tumor, you can't say that. That's not the case. So it's actually a pretty good example of differences between genomic profiling in tumor and plasma. In terms of interpreting it in the plasma, it's quite difficult on its own, I would say, and usually would be done in the context of other measurements as well, in terms of establishing clonality and subclonality.
Yeah, similar. You know, I think there's a misnomer. I hear this commonly. Well, a 10% mutation must be more important than a 1% mutation. And that's not true because you have to take it within context of the tumor fraction. If the tumor fraction is 2%, a 1% alteration is actually a clonal alteration, meaning making up the majority of the tumor cells. And so there's a lot of education that has to be done, particularly among clinicians, on how you interpret allele fraction within the context of tumor fraction and then being able to interpret the biology.
I have just one point to add here, because I think now that we're moving into a world where we're doing multi-gene sequencing in a more systematic manner, the opportunity of reporting not variant allelic fractions, but actually cancer cell fractions for the alterations will greatly improve our ability to interpret it in a meaningful way. Exactly the point. We integrate the amount of DNA coming from the tumor with the local copy number, the ploidy of the tumor, and then we say this mutation is present in 3% or 90% or 100% of the tumor cells. And I think it is by integrating copy number mutation, structural variants all together in terms of our results, we'll be able to render much more informed decisions clinically.
Over.
Thank you, Andy Stiebel, Newport Beach, California. That was really interesting. I may be more confused than I was when I walked in. But with the last comment that was made, can you help still elucidate, as you said, when we do this, how it helps? Is it first site of metastatic disease? Do we follow PATA and do this like every few months? Do we do it with the second site of metastatic disease upon progression every single time? This is what I'm still trying to get some guidance.
That's such an important point because it is evolving. For instance, in the context of endocrine therapy and progression upon endocrine therapy, now we have a reason to be surveying for the presence of ESR1 mutations at every progression. So that's your answer. But there, given the way ESR1 mutations, because they are heterogeneous in different metastatic deposits, it's important then that we are able to survey all deposits at the same time. So in that context, then we have to call Ben to actually do the liquid biopsy because it's more representative. This is a field that's evolving, and now that we have adequate tools or compounds or agents to treat these patients effectively, the way that the testing will be done will evolve. It's inevitable.
If a person has a pathogenic germline variant in BRCA or a different homologous recombination gene, and they have a sporadic cancer, and do they respond to the PARP inhibitors, for example? I mean, why is it that that seems to be the exception? We're checking the germline instead of the tumor.
That's how the trials were designed, and the approval is...
Yeah, I assume that. But,
yes.
But realistically, if you have a 75-year-old woman with no family history of breast cancer who happens to have a germline mutation in BRCA, it seems that it's more likely she has a sporadic breast cancer than a BRCA-related breast cancer, and I would suspect that she's among the 40% that don't respond to the PARP inhibitor or don't benefit from the adjuvant. Is that true? Is that known?
That's a great point. In molecular tumor boards, it's often discussed when tumor normal multi-gene sequencing is available. They adjudicate cases of this nature on the basis of a biallelic alteration or not. Does that make sense?
Yeah, it would sound, when you say that, it makes me think that testing the tumor is more the issue than having the germline mutation.
But we have no proof here that there is no benefit at present.
So that
the approval is with the way it's reported for the different PARP inhibitors on the basis of the genomic alterations that the clinical trials were carried out with.
One other quick question. If somebody has a chip, say in P53, you kind of alluded to the fact that they're at risk for acute leukemia, for example. Are there guidelines for what to do with those patients, since so many of them are now surviving their metastatic disease?
Yeah.
If you report 29% have a CHIP, and it's a person who's likely to live for years with their metastatic disease, are you following to see what the allelic fraction becomes over time?
You know, it's a really good question. Obviously, the vast majority of these patients who have CHIP mutations don't have a secondary malignancy. So if you check out their CBCs or their blood work, you don't see any abnormality. Where we begin to get worried, though, is if you do begin to see a significant increase in the allele frequency of a particular alteration, like 53, if it starts creeping up substantially, I think some more in-depth clinical correlation is definitely warranted. Where I get even a little bit more fearful is that we had some excellent data in the ovarian literature that patients who have been exposed to a platinum plus a PARP inhibitor, when they had a CHIP alteration, were much higher risk of developing a secondary malignancy. So I think, secondary hematological malignancy. So I think in the clinical context, we'll want to obviously, pay close attention.
Thank you.
Hi, David Rim from Yale. My question is predominantly for Dr. Radovich, but the others can chime in as well. So the Achilles heel of sequencing is that it's slow and it's expensive. And you showed us an alternative, that is to look at the H&E with deep learning and AI and figure out the percentage of patients or the likelihood of a patient's having a given mutation. Can you comment on whether or not you can go to a place on the curve that gives you such high sensitivity that you would be willing to do that first on every patient?
Yeah, it's actually been an interesting debate we've had internally, where we could tune the algorithms to the ROC curves, where we have basically, maximal specificity and maintain some sensitivity. If those patients are positive, acting on that quicker. I think there definitely is a future for that. I think about, especially when we have targeted therapies that are being used in the first line, we don't want to wait 2 weeks for the results to come back. We want to be able to get those patients on therapy immediately. I think that use case is going to be very helpful, exactly as you stated.
David, it's a great question. It's something that the two of us are passionate about and have been passionate about for a few years. I'm going to make a shameless plug for tomorrow morning in the plenary session. Freja Pareja will be presenting, for instance, how we can devise a deep learning algorithm to detect lobular carcinomas, but trained on CDH1 mutations. So leveraging it the other way around, yes? Like Milan exemplified. We can actually then recognize those CDH1 alterations above and beyond what we could detect with sequencing, which was really interesting. But this is a very specific and very narrow alteration because it produces a phenotype. I find what Milan presented really exciting, but we have to remember that the phenotype caused by some genomic alterations is much less conspicuous, and we would need incredibly large data sets to be able to ascertain what the, let's say, embeddings and vectors would be for us to detect that type of cancer. But I agree with Milan, that's the future, likely the future.
So as a follow-up question, how many mutations that are important are impossible to detect with AI?
I have no idea.
But this, David, will be answered in the near future with these foundation models that are being developed. When we have several tens of millions of slides analyzed, we'll be in a position of actually answering exactly your question.
So my question is along the lines that David just asked. We know that an average cancer solid tumor may have a mutation of anywhere between 0 or 1 to 10, 20, 50 per megabase. And the genome has 1,000 megabases. So any cancer cell probably has somewhere around 2,000 to 3,000 mutations. Does the H&E profile provide you a better idea about the driver versus the non-driver mutations?
I think it can, because it's giving actually, as I mentioned, I think it's giving a phenotypic readout, right? And if trained appropriately, can do so. Now, what it's not going to do is tell you the composition of all the different molecular alterations. What we don't know is what happens when there's co-occurring drivers that may be difficult to adjudicate both. So these are the things where I think it's going to be difficult. But what I do like about it, again, as I mentioned, the AI doesn't know that there's a BRAF mutation. It just says, hey, there's something here that looks conspicuous, and it looks like it's maybe based off machine learning driven by BRAF. Yeah.
So George, you are smiling. Your thoughts?
Sunil, that's a phenomenal question, as usual. There was some data presented by the French group, by Anne Vincent-Solomon, in terms of HRD, and using this information exactly for the purpose of what you're discussing. Before I transitioned to AstraZeneca, I was involved in a project with Jakob Kater, also looking at HRD and trying to classify some of the variants on the basis of the phenotypic outputs detected by deep learning. It's really a fascinating application of the technology. The problem is that we don't have numbers yet, sufficient numbers for us to define the realm of phenotypic features to a sufficient level of granularity that the classification would be sufficiently accurate.
Yeah. All that being said, the data I showed you is being trained on hundreds of thousands of cases.
No, but Milan, I have to say, looking at the work by Thomas Fuchs, just for cancer detection, the inflection point for accuracy happened around 40,000 whole slide images. And if you think about then more granular phenotypic features, probably we're talking about millions.
Yep.
Great talks. My name is Marissa Gentile. I'm a pathologist from Garden Health. One comment on the identification of CHIP is, we really recommend looking for CBC abnormalities in the context of finding these mutations. And you do find that these mutations are very different from solid tumor molecular abnormalities. My question is for the gentleman from Caris. Are you planning on using your sophisticated algorithms to build a model to filter out CHIP instead of sequencing the Buffy coat?
I mean, obviously, we've seen the published literature, and I think, obviously there's mechanisms of using algorithmic-based methods to filter. And as you rightly stated, a lot of these mutations occur in prototypical genes like DNMT3A, ASXL1, so on and so forth, TET2. So, you can have confidence or very high confidence there of CHIP origin. Where things become a little bit more tricky is more on the rare end, where you have mutations in prototypical oncogenes that have therapeutic associations. We've seen, a few that were, again, in BRAF, a few in KRAS, a few in PIK3CA that were definitively of CHIP origin. The filtration methods may not necessarily get those. Now, I know there's been some recent data using the fragment sizes as well as a way to get it. So for us, for now, sticking to very deep sequencing of the Buffy code just gives us complete confidence that we can detect and not have anything on the fringes.
And so as a follow-up, are you able to detect 100% of your CHIP variants by very deep sequencing of the Buffy code?
We don't know yet. No, I think that's still an open question. The reference of CHIP variants, it's more incidental in terms of determination. Whether you can detect 100% is still a question, because the other piece that I did not highlight is, we talk a lot about CHIP mutations. There's also this concept of CHIP-based translocation, or MCA types of events. Those are things that are kind of evolving and being validated.
I'd just add to that in terms of the work from the Sanger that's shown, that clonal expansion in a hematopoietic stem cell compartment is normal spectrum as well in terms of,
There's also another thing that I didn't bring up, but when we think about CHIP, we always think about, we commonly think about mutations present in the circulating component, but there is also a CHIP source that comes from megakaryocytes, primarily in the bone marrow, and so those pieces are a little bit more difficult, obviously, to correct for those alterations.
One final CHIP question that came in online is there any role of applying screening guidelines for patients who have sporadic or CHIP mutations in TP53 or BRCA?
I would stick to the results of the St. Gallen consensus this year. I have to say that my opinion was a defeated vote. So my recommendation is to follow the guidelines. I have to say that in my previous institution, the way we went about the sequencing for germline alterations was much more systematic.
But I guess as a follow-up to this particular question, if somebody has CHIP detected in P53, it's not the same as having Li-Fraumeni.
That's correct. Now, that's exactly right. And you can You can tell a little bit by the allele frequencies, and a good medical geneticist to really differentiate chip origin versus being of germline origin. Now, where things get a little bit tricky is when these allele frequencies are kind of in the area of concern from germline mosaicism. So you're in that above 20% range, but you're below the 40 to 50% range, and there obviously you need some more intricate follow-up formal germline testing.
There's an important point. The work by Fraser Pareja and Diana Mandelker that made the cover of Cancer Discovery in April 2022. They demonstrated that there is 1 in every 1,000 metastatic cancer patients have somatic mosaicism affecting cancer susceptibility genes, pathogenic variants that result in a phenotypic output. And I think this is rare, it's 1 in 1,000, but it does exist.
So to bring it back to a little bit more practical level for what we can do tomorrow in clinic, one question that came in online is, will insurance pay for more than 1 liquid biopsy for monitoring for emergence of mutations? And so I guess just sort of in a bigger picture, how should we be using these liquid biopsies in your opinion? Should we be using them the way PATA-1 does, to be following to see if people have emergence of minimal, detectable disease? Should we only be using them at the time of clear disease progression based on symptoms or scans?
Yeah, so I'm a UK doctor, so we'll be ordering 0 liquid biopsy tests that are funded by our National Health Service until we have proven clinical impact from these interventions. So obviously it's a different situation in different parts of the world, but yeah, I think it's really important that we do these interventional studies and prove benefit. Obviously, some of the licensing and approvals do cover liquid biopsy for the metastatic profiling that George was discussing, and one of the questioners over there. I mean, I'm not sure in terms of the local provision. I don't know whether the US guys want to comment. Doesn't look like they do.
I don't want to give my views on insurance companies.
But I guess as an extension of that is, when would you think about doing next generation sequencing for a patient who has a triple negative breast cancer versus an ER positive breast cancer versus a HER2 positive breast cancer? And would you be using tumor preferentially or liquid, or does that change over time?
I think it definitely changes over time. I think, in agreement with my colleagues, I think all metastatic patients should get genomic sequencing irrespective of subtype. I think there is a lot of credence to also consider high-risk early-stage patients, particularly as we've seen more emergence of clinical trials of use of targeted therapies in the post-neoadjuvant setting. I think is definitely helpful. And then when it comes to liquid versus tissue, obviously tissue still remains, the most highly sensitive technique. However, as I showed during the talk, and as my colleagues have shown, liquid gives us a better snapshot of heterogeneity, a better snapshot of emergence of resistance. And then what actually happens commonly clinically is you have a newly diagnosed metastatic patient. That metastatic biopsy may have been scant, so it's not good for sequencing. A lot of times you go to the original surgical resection that may have been several years back. Again, we'll give you a lot of sensitivity, but you want a current snapshot, so you do a concurrent liquid biopsy to take a holistic genomic picture of a patient.
So I'd just add to that actually in relation to the questionnaire that we had, which I can't remember where from, sorry, but it was about when do I do these tests, in what context? And I think what we are always going to see is that's going to be a bit of a movable feast. It's a bit like George showed us with that algorithm. He said this algorithm is going to change in 2 weeks' time. So I think we're going to have these particular contexts where we're more comfortable in saying actually we should be doing this test like on aromatase inhibitor therapy where we're looking for a particular emergence of a genomic mechanism of resistance. But I think we may never reach a point where there is a nailed down guidance in terms of exactly what you do and when, just because the patient journey can be so different and variable.
Yeah, one other quick question about the ESR. So, Medicare has apparently approved circulating tumor DNA testing for patients on adjuvant endocrine therapy. If you have a tumor-informed, if it's a personalized assay like Signatera, will it pick up an ESR mutation that's floating around, since those only happen once you've, since the assay is based on the original tumor and the mutation occurs in 40% of the people who progress.
Yeah, so that's a really good question that kind of strikes at the heart of, you can only see what you're looking for in these circulating tumor DNA assays, right? And so if your question is just to detect or not detect the cancer, then you might take a different approach than if your job is to...
That is kind of the question. I mean, that's the whole point of MDR, is it not?
Yeah, so, but you can't do discovery unless, you know, for mutations in genes that you're not expecting.
I mean, in the assays that are not reliant on the original tumor, do they look for ESR, since 40% of the time that's the mutation that occurs when they progress?
I think just there's a little confusion because you're talking actually in the MRD setting, as I think is what you're referring to. Yeah.
So you're absolutely right. It's a great point. With the tumor-informed assays, we are detecting MRD. We're not doing liquid biopsies. These are different purposes. It's ctDNA, but different applications. Yeah. We are seeing now a new wave of assays that actually combine the tumor-informed aspects with the liquid biopsy aspects in the same assay.
So once you've established that they have metastatic disease, then you would do a liquid biopsy to see if ESR is floating around. Mm-hmm. And you said in the European guidelines, the liquid is the preferred assay to do for ESR.
Yes.
The studies that showed the efficacy of the drugs that target the ESR mutation, were those based on tumor next generation sequencing or liquid next generation sequencing?
Both.
Both.
So would you expect the response rate to be as remarkable if it's on the liquid, where the basis for the ESR being seen has to do with the heterogeneity of the tumor?
That's a really good question. I don't think that's possible to answer in terms of the data that we have.
Thank you.
So sort of related to that question, but thinking about the AKT, PI3 kinase, PTEN, with the new drugs that we have, most of us don't have access to molecular tumor boards at our institutions, and we're having to get these reports on our patients and then decide what to do. So from a practical standpoint, what do people need to think about when they're thinking about using alpelisib or capivasertib, you know, because not all mutations are equal?
Well, you know, I think there's, obviously we don't have head-to-head studies, so we can't talk about the therapeutic efficacy, but I think, you know, important difference is with alpelisib, that's just for PIK3CA only. With capivasertib, it's PIK3CA plus AKT plus PTEN. So by definition, if it's AKT or PTEN mutated, you're obviously going to go after an AKT inhibitor. You know, I think, though, you're absolutely right. I mean, the amount of evidence that's coming out in this space on a near weekly basis is almost overwhelming, and I think, you know, molecular tumor boards obviously help substantially, but obviously, you know, the reports themselves need to always be up with the most updated evidence to make sure our physicians have the knowledge they need to make the appropriate decisions.
I guess the other thing, just to ask you to comment on, oh, sorry. I was going to say, but related to that, so with, you know, if someone's tumor has a PTEN mutation in it, does that necessarily mean that they're a candidate for the new drug? Or are there certain mutations, certain alterations that people should be preferentially looking for when they're trying to decide if someone is a candidate for mutation?
Well, you know, interestingly, so with PTEN, it's a little bit interesting because those mutations are typically loss-of-function mutations. So tumor suppressors don't have the oncogenic hotspots like you have with oncogenes. So you can have frame shift alterations that occur, as you know, across the gene, and we know in most cases all of them lead to a loss-of-function phenotype. When it comes to the gain-of-function mutations, AKT, almost all the mutations occur at the same codon, at codon 17, so that's pretty straightforward. With PIK3CA, you know, there's two major hotspots for the most mutation, but there are some others. You know, when you look at the trials, not every single PIK3CA mutation that we know is gain-of-function were enrolled on the studies, so we can really work primarily with what are called the PI mutations, which were the ones that were primarily tested. The jury's still a little bit out there on those non-PI alterations.
quick question. As was just said, that a mutation is not a mutation. It can vary depending on the location.
Mm-hmm.
So question to you and to George, does the location of the mutation matter in terms of whether it's lobular or non-lobular in a E-cadherin or in any other gene, whether the phenotype is reflected in the genotype and the genotype reflected in the phenotype?
That's such a great point, Sunil, because for some genes, yes, it does, because the functional domains are distinct. For the loss of function mutations, given that the ones that are really pathogenic result in complete loss of expression and function of the gene, they matter a bit less. But there is evidence for that as well, okay? Small, very selected case. But in terms of oncogenes, if there's more than one hotspot, the phenotypic output of different mutations may differ, which is really interesting. But it's an underexplored area, and more research needs to be done from a clinical standpoint, let's put it this way.
Yeah. I mean, there's obviously pathognomonic mutations, for sure.
Yeah.
Actually, one of our favorites, Sunil, is in thymoma, as you're well aware.
You
so there's only one GTF2I mutation, the others don't work. So the answer is yes, but I think the jury's out for when we see non-pathognomonic mutations, you know, do we see the same response? And PI3K is one example.
So the question is, do you see the phenotype change that you would identify looking at an H&E by machine learning or multiple instance learning?
It's a great question. I don't know that answer. I don't. You know, I mean, a lot of the efforts, as George rightly pointed, you need large numbers of slides and sequences, and so, you know, being able to have enough diversity for those more rare alterations is tougher.
Thank you very much, everybody. It is 5 o'clock, and the session is closed. Thank you so much to our presenters, and thank you to those of you who asked questions as well.